So this is what I was talking about. This is flacs in a small pupil and a hard cataract, but it's not as simple as that. So a small pupil, yes, as I mentioned, you have to use BSS in the anterior chamber, remove the viscoelastic. Do you need to take a suture or not? I don't take a suture, okay? And the ring is on the pupil, but then the viscoelastic has to be removed from the anterior chamber. You can't leave the viscoelastic in the anterior chamber. If this is a small pupil, we have different causes of problems. One is the AC will flatten out in case you don't have it, but the challenge is in energy setting. So if you leave any viscoelastic in the anterior chamber, you may need to increase your energy in the femto, and a suture is really not necessary. So coming to how this case was, I always say this was what I found when I was driving in the US. Staying in bed and screaming, "Oh God," does not mean you're going to church. So you have to know whatever you're doing. So this is a case I wanted to present. It's quite a challenging case. I'll tell you what all it went through. It's a small pupil, irregular shallow anterior chamber, angle closure attack of glaucoma, peripheral iridectomy done, patient has prostate, patient has a hard cataract, and patient needs a femto. And one more thing, patient has a subluxation. So now the complexity begins, and patient wishes to have a femto. So this is the case. You can see the irregular anterior chamber, you can see a peripheral iridectomy, you can see a sphincter atrophy because of the angle closure attack of glaucoma, and you can see the subluxation. So this is all that the pupil dilates. The pupil doesn't dilate more than this. And you can see the subluxation, and you can see the peripheral iridectomy. And now this is not as soft as you think it is. This cataract is quite hard and quite dense. So this was what to do now. So question here is, we started with the procedure. Yes, we have video on as image guided procedure. We go ahead and make our main incision. Once the main incision is made, we put in a viscoelastic. So you can see that we're making the main incision in the axis as planned, put in the viscoelastic, and here I'm going ahead and putting the Malugan ring. So to put the Malugan ring as shown by Dr. Harshul is now quite easy. The plunger is just going in. You have to scroll one end of the loop into the iris, and you can do it as a one-step procedure. So you need to tilt your hand a little bit to the left, a little bit to the right, get the iris into the loop, and you are done. So in one shot, you're getting 3 loops into the iris. You can even do the 4th one at one shot. I use a Krugner's hook. That's the right instrument. Don't use a Sinskey hook. Don't use anything else. If you use a Sinskey hook, sometimes it slips and the whole scroll will go behind the iris. So here, whatever I used, I'm not sure, but I'm using something from the superior incision, and then making sure that I go ahead and engage the iris. So this is the Krugner's hook. Go ahead through the side port to engage the sub-incisional iris. This will never ever slip. If you use a Sinskey hook, it can still slip and it can still fall behind. So now I got an adequate pupil. You still think it's a soft cataract. It is not. So it's an illusion that you're getting. Now the next step is to remove the viscoelastic, okay, from the anterior chamber. And as I mentioned, a little bit of elongevity along the inner lip of the incision, because this incision is 2.2. And then as you see that I have done the femtorexis, I've also done the 4-segment or 8-segment division. Here I've also done that. You can see the 8-segment division. But I'll just tell you what happened on the femto. So you can see here, this is the femto bit of it. So you can see the Malugan ring in place, 1. You can see the distance between the iris in both the different areas. So that shows that this lens is subluxated. And you can also see that bowing down of this part of the lens. So this is a subluxated cataract, a hard cataract, Malugan ring in place. And then I'm going ahead and doing the rexis. 8-segment fragmentation is also quite possible here. So 1.2 millimeter rexis, 8-segment fragmentation, and we are all sorted. So this is all in place, right? So now let's go back to the case. I've started, the rexis is removed, and I've started phacoemulsification. So you can see the same ring is in place. Now notice 2-3 things. The whole nucleus shakes, obviously, because there's no counterbalance, there's no counter traction, there is no support, and there is a subluxation. So 2-3 take-home messages from this whole video you will get. I'm trying to rotate the nucleus. I'm not able to rotate this nucleus, the main reason being subluxation, right? So I'm not supporting the bag. This is not the right thing to do. Always support the bag before you start grooving. That was one thing I realized over time, that yes, this is not the right thing to do. So next time, of course, I will be putting in the hooks much earlier. So I go ahead, I realize that I'm trying to rotate it bimanually, it's still not happening. So then ultimately I could get a little bit of bimanual rotation of the nucleus. Now I go ahead and put, unfortunately that day I must have not had capsular hooks. I'm using iris hooks. Now this is not the right thing to do, friends. Definitely you should use capsular hooks. From that day I've started keeping almost 2 of iris hooks and 2 of capsular hooks in the OT. So always it is there as a standby and there's never an issue. So now as you notice, moment I supported the capsular bag a little bit, the rotation became much easier. So go ahead and do your phacoemulsification, doing that, and then removing the nucleus one by one, one by one, one by one. Now, as soon as I was doing this part of the nucleus disassembly and removal, I realized that even superonasal, where my chopper is, the bag is little weak. So now I have the Mulligan ring in place, I have one iris hook in place, but I'm still not happy with the support that the bag is getting. So then I decided that yes, I need to go ahead and put one more hook there. So this is the epinucleus, the main nucleus is out, but I decided that yes, this area the bag needs support. So I go ahead and put one more hook there and support the bag. And then I remove the epinucleus, etc. So now this is all good. This will be followed by bimanual IA. We know that there is a subluxation. So this has to be then supported with an endocapsular ring. Now as far as the trick of inserting an endocapsular ring is, always start placing the endocapsular ring in the direction opposite to the area of subluxation. So if the subluxation is here, do not start putting the endocapsular ring from here, because if you do that, your 2 eyelets will come in the same area of the subluxation. So always start putting the subluxation the endocapsular ring in the area opposite to the subluxation. It's a very simple trick that you take home. And once this is done, I'm just doing a bimanual IA, which a little lower bottle height. So now you can see that the bag is held well, okay, and everything is going fine. And now, as I mentioned, I'm putting the endocapsular ring in the area opposite to that of the subluxation. So if you had capsular hooks here instead of iris hooks, one more thing we have to remember, that the capsular hooks have to be made a little loose before we put the endocapsular ring. If that's not done, again there will be entanglement there at that level. Luckily I had iris hooks, it's not reaching the equator of the lens at all, so that is quite safe. But if I had capsular hooks, I normally loosen them a little bit and then I put the endocapsular hook. There are 2 types of capsular hooks. These capsular hooks which I use are made by Madhu, no financial interest. They don't have a large area of hook in the periphery, but some of the capsular hooks which cover a larger area of the equator have a loop, and that's where you have to be even more careful. So the endocapsular ring goes in place. I have the Mulligan ring in place. I have 2 hooks in place. And then I'm going to put an IOL in the same area of subluxation. So I'm going to further support this area of subluxation there. So this is very simple. And then just release it inside. And just rotate your hook and it goes in. So this whole area of subluxation is well supported. Put in a single piece IOL into the bag. The haptic further supports your area of subluxation. And then that is followed by removal of the hooks and removal of the Mulligan ring. At one stage I thought I did get a vitreous strand there, so I think I did a little bit of vitrectomy and then made sure that there is nothing there, and it was all done. So you can still see that PI, and this was a subluxated case. So thank you all for your attention.